And today we're going to talk about a very interesting topic about how hyperandrogenism can really be beyond PCOS. So generally speaking, we have all been tuned to the fact that a lot of patients who come to us are actually having hyperandrogenism, and we start diagnosing with regards to a polycystic ovarian syndrome because 95% cases are like that. But today we'll highlight how we have different aspects of PCOS, hyperandrogenism, which can cause PCOS in that regards, and that becomes important. So we'll try to cover the other organ which is there in terms of hyperandrogenism, and that is adrenals. We will use 4 cases which will highlight the different spectrum as to when we should suspect, how to evaluate, and how there could be a diagnostic confusion in that regards, and this is how we will proceed from there. So I'll start off with an index case, which is a reasonably common scenario, which we would be thinking of in particular situations wherein you have implications in terms of diagnosis and management. So this was a 14-year-old girl with hirsutism, and on that situation, this girl basically had menarche 1 year ago. Periods were happening every 2 months. There was virilization and muscularity, Ferriman-Galway score of 18, and she had a PCO appearance on ultrasound. So she was labeled, quote unquote, as PCOD. Now, Dr. Sain, do you agree with this diagnosis? So if you have anybody who has virilization, who has muscularity, who has significant FGS or a testosterone level which is more than 1.5 nanogram per DL or more than 150 nanogram per 1.5 nanogram per ml or 150 nanogram per DL, you have to start doing imaging. And what we found was a large heterogeneous lesion, which was an adrenal carcinoma. So while we consider that often, if we talk about hyperandrogenism, 85% will be PCOS, there are other possibilities also which we need to be wary about. The most common cause will be 21-hydroxylase deficiency, the non-PCOS cause around 5% cases, tumor around 1% cases, and 7% is idiopathic. So when you say idiopathic hyperandrogenism, what are the possible causes that you're looking at, Dr. Vibha? So they will be secondary causes anyway. So idiopathic would mean, one, there is more sensitivity to the androgen. So there will be more sensitivity there. They are part of PCOS. So when you say PCOS, PCOS is actually functional ovarian hyperandrogenism. That is what PCOS is. So idiopathic may mean that there is a peripheral production of androgens in obesity. That is one scenario, or the sensitivity is more. So these are the important things to remember. So while 85% are PCOS, you have to worry about these 5% of 21-hydroxylase where you have a different therapy, and of course 1% which is very, very significant. So Dr. Naveen, what are the signs that you will think that this is more likely to be a adrenal etiology rather than PCOD in a girl who presented to you with features of hyperandrogenism?
So the sign of red flags and we need to look for, which is in the form of virilization, steroidogenesis, or any voice change and any.
So if you have features of virilization, which basically means voice change, clitoromegaly, muscularity, those things. So these are one big group of signs. This is for any tumor. What else?
An FGS score of.
That is fine. So that is part of severe hyperandrogenism. So early onset is a very important sign. So if you get a history that this girl had pubic hair growth which was there for a long time and now they have increased, then you think of congenital cause becomes important. Child was absolutely normal and now suddenly there is a lot of hyperandrogenism happening around 18 years, 20 years. Think of an adrenal carcinoma. 30, 40 years old, ovarian carcinoma will be there. So timing becomes important. So severe, again we said, soon is something which is there. Of course, if there is a family history, you will look at. What will be the syndromic features of 21-hydroxylase deficiency? So what will point more towards 21-hydroxylase deficiency?
21-hydroxylase is something that in case if it is from birth, if someone is having
so that is soon, severe, syndromic. What are the features of syndromic? What is syndromic for 21-hydroxylase deficiency?
Advanced bone age, which is
so that will be more, so pigmentation. That will be an important factor to look at, pigmentation. If of course salt wasting, you won't be missing. What else? What else clinical clues you will look at? What will you measure on examination in a girl who comes to you with hyperandrogenism? So blood pressure, it could be 11-hydroxylase deficiency. It could be a tumor which is present on that. So generally, as we were talking about delayed puberty in boys, we say, okay, 80% is CDGP. But if you have somebody who is tall, who has pubic hair development, who has a stalled puberty, who has some syndromic features like anosmia, synkinesis, neurological features, think of a secondary cause. 85% of girls who present to you with hyperandrogenism will have PCOS. But if it is very severe, FGS more than 15, or if you have virilization, if it's too soon, like onset before puberty, if you have syndromic features, like you have pigmentation, like you have hypertension, and if there is a family history, think of an alternate cause. And what we are going to do is that we'll have 4 cases which will illustrate these scenarios and go into that in that perspective. All of you can go and have a look at our website, learning.growthsociety.in, which has got a lot of interactive videos along with other tools for pediatric endocrine training. There are courses available, including fellowship and diploma courses. We run regular grand rounds in the form of a PG lecture series, which happens in the evening on Saturdays. And these grand rounds, which we run here, there are publications which cover the entirety of pediatric endocrinology, our app, and all those things you can access. So in today's grand round, we will have 4 cases which will highlight these scenarios. But before we do that, we will set the background by understanding what really is hyperandrogenism, what is adrenal hyperandrogenism, and then we can apply it in our clinical practice. So we know that 50% of androgen in women and even adolescents come from the ovary, and this is largely regulated via the luteinizing hormone. And this is via production of androstenedione. The remaining 50% comes from the adrenal, which is controlled via the ACTH. So this is a basic philosophy which comes via DHEAS, which gets converted into both androstenedione and testosterone in that perspective. And these all will then get peripherally converted via 17-beta-HSD into testosterone, which will then get activated to dihydro, which is the active form. So half of your androgen is coming from testosterone, from the adrenals. Half is coming from the ovaries. So now if you have an adrenal form of hyperandrogenism, Dr. Sayan, which metabolites will be high on the blood examination? So you will have high testosterone and high DHEAS in a adrenal pathology and a high androstenedione and testosterone in a ovarian pathology. What about androstenedione in adrenals?
Androstenedione is not the primary metabolite of that.
Will it be high? Will it be low? It will be normal.
If DHA is high,
andro will also be high, because if DHEAS is high, andro will be high, DHT, testo, everything will be high. So don't get a notion that if you have high androstenedione and you have not looked into DHEAS, this is not adrenal. So message is DHEAS elevation is more specific. Androstenedione elevation is not specific from ovarian, because it will also come from the adrenal. So DHEAS is the best marker in terms of that. When you assess DHEAS, Dr. Vibha, what precautions will you take? What time the sample should be taken? Why? It is sulfated. So DHEAS is sulfated, so therefore it is not affected by diurnal rhythm. You can take it any time of the day, as against many of the other adrenal hormones which you have to take on a specific notification in that regards. So now in hyperandrogenism, we said you can have physiological causes, but within pathology, ovarian is by far the most common, followed by adrenal. So we are focusing today entirely on adrenal. We'll be talking about steroidogenic defects, we'll be talking about tumors, and all those scenarios will come up. So we need to understand about adrenal steroidogenesis a bit. So we all know that the initial pathway is common, conversion of cholesterol into deprogesterone using star, side chain cleavage, and 3-beta-HSD. This is then converted via 21-hydroxylase, 11-hydroxylase, and then other enzymes into different forms, converted into, of course, cortisol, aldosterone, and DHEA, which is then converted into DHEAS and then gets activated. So defects in any of these may have a situation in which you have cortisol deficiency and you have secondary increased ACTH production causing hyperandrogenism. So Dr. Naveen, which all enzyme defects out of these will cause hyperandrogenism? So if you have 21 hydroxylase deficiency, of course, you will have high along with salt wasting, or if the levels are fine, you will have a normal salt status, but you will have hyperandrogenism. Second, so if you have 11 hydroxylase, you will have mineralocorticoid excess, you will have hypertension, hypokalemia, alkalosis, along with that you will have virilization. What else? So if you have a 3-beta HSD problem, you will have peripheral conversion, you will have milder level of hyperandrogenism. So they will be not, they may actually have virilization, but they will not have a complete Prader 4, Prader 5 staging because it's peripheral conversion. Any other defect can cause this? So these defects will also have an effect because they are involved in conversion of the cortisol and DHEA to DHEAS. That is important. And if you have free DHEA, it is going to be converted more. If it becomes DHEAS, it is stored and you don't have a rapid conversion from that perspective. So if you have a problem in the sulfonyl transferase or the H6B6, you will have a problem. So 3-beta HSD defect, if you give ACTH, you will have a very, very high level of DHEAS. I said DHEAS is a specific marker of adrenal etiology. DHEAS more than 700. Think of a tumor / 3-beta HSD deficiency. 400 to 700 more like a FAH picture. Now you also need to understand that you need to take all these levels together. So if you say DHEAS is high, and testosterone is high, because of a CAH, then your 17-OHP should also be high. You can't have a lowish 17-OHP or low normal 17-OHP and a very high DHEAS because these are all distal pathways. First thing you need to understand what is high. So DHEAS will be very high here and 17-hydroxypregnenolone levels will be very high. Now 21-hydroxylase, we all know 17-OHP will be high, and if you give a ACTH stimulation, the level will go further high. 11 DOC levels will go high in that scenario. If you have a sulfonyl transferase defect, the DHEAS is there, it is not getting sulfated. So it is going to be converted more into androgens, and this is going to cause more problem in that regards. If you have a 11-beta HSD1 defect, what will happen? We all know about 11-beta HSD2 defect. What happens in 11-beta HSD2?
Functional cortisol deficiency, ACTH stimulation, increasing androgens.
So this is the 11-beta HSD1 defect in which cortisol is not getting produced from cortisol. So you will have cortisol deficiency and you will have high ACTH and you will have DHEAS which will be produced in that regards. All these cases will have a common scenario of high ACTH causing pigmentation. So pigmentation becomes an important thing to look at in any girl who comes to you with hyperandrogenism. Can you have non-CAH causes of hyperandrogenism where you have pigmentation? So there is some other cause which is not congenital adrenal hyperplasia, but the girl is pigmented. ACTH dependent Cushing syndrome. But there the ACTH is not very high, so there will be mildish pigmentation, not like CAH where you may have severe pigmentation in that scenario. So these will be the scenario to look at and go for. So basically I discussed non-classical 3-beta HSD. So we are talking about non-classical forms. Classical forms will present to you with atypical genitalia, disorder of sexual development right at birth. So non-classical 3-beta HSD, very high 17-hydroxypregnenolone. But remember, biochemical tests are not foolproof of having a particular enzyme defect. The foolproof is genetic test. And as Sayan had presented nicely in our Advanced Pediatric Endocrine Symposium, there are scenarios in which you have very high levels of 17-hydroxypregnenolone, but they turn out to be FAH, functional adrenal hyperandrogenism, but genetic test is normal. Non-classical 21-hydroxylase deficiency is also self-limiting. 17-OHP will be high. Now, when you say non-classical 21-hydroxylase deficiency, Dr. Naveen, what is the usual presentation in that scenario?
They usually present with features of hyperandrogenism, polycystic ovarian disease, oligomenorrhea, thyroid defect.
So, what will be the severity in that case?
The severity is usually between 8 to 15 of FGS score, which is not associated with virilization. So
when you have somebody who has got voice change, somebody who's got muscularity, somebody who's got clitoromegaly, you cannot and should not label that child as non-classical CAH. So many times you will see, and this is interesting, when you have a tumor, it will actually be producing 17-OHP also as part of the deranged steroidogenesis. If your 17-OHP is mildly elevated and you say, okay, this is non-classical CAH, but that non-classical CAH will not have a testosterone more than 200. It cannot have. It will be like 60, 80, something like that. It will not have virilization. It will not have clitoromegaly. So this point is important, that always correlate 17-OHP level to the level of elevation, which is of testosterone. Non-classical 11 will have milder disorder, and this will cause more like a hypertension will be there, but again it can be mild. SULT2A1 deficiency, again it's premature pubarchy, not like a typical virilization, and then again conversion, you will get a diagnosis in that regards. Now we all know that CAH will cause hyperandrogenism, but what are the specific mechanisms by which CAH will cause hyperandrogenism? The first mechanism we of course know is that adrenals are producing a lot of DHEAs that is causing that. But remember, this will also get converted into testosterone, and this testosterone will go to the ovaries and hyperandrogenism begets hyperandrogenism. So if you have high testosterone, the ovary becomes producing more androgen. So this is the second mechanism which happens. What are the other mechanisms by which CAH causes hyperandrogenism, Dr. Sayan?
There are certain adrenal rests in the ovaries that can also, and prolonged hyperandrogenism will cause a reset LH axis. So that will also drive the production.
So you may have adrenal rests which are resting in the ovaries, and if you have uncontrolled CAH, they can start producing androgens there. What we have talked about also is very important, is a prenatal exposure. So normally progesterone inhibits LH secretion. But if you have prenatal hyperandrogenism, this inhibition goes off. So your hyper LH state will be there in CAH. So if you have CAH and you are controlling your 17-OHP well, still you can have hyperandrogenism because you have this antenatal phenomena which is working, and ovaries may have gone into hyperdrive because they already have a high level of testosterone exposure which is there in that scenario, and that becomes important in that regard. Now, adrenal tumor we talked about is usually carcinoma. Now, this is important. Normally, when we say if you have a virilizing adrenal tumor, we always say carcinoma. But this may get confusing when we discuss our cases today. It is a rapidly progressive, so it can't be 8-year history, 9-year history. It has to be within a year or so. You will get a history, and management is very difficult. Poor prognosis, surgery, mitotane, these things can be considered. So now once you know that this is hyperandrogenism, you have significant elevation of testosterone beyond 55, or you have FGH which is more than 15 or 8 to 15 with high androgens, you know it is not related to puberty, then you think of a pathological cause. The first question is it ovarian or is it adrenal? So to answer that question, we have already discussed that you look at, if it's ovarian, you will have a normal DHEAs and a high androstenedione. Adrenal, remember, andro can still be high. So don't get fooled that your andro is high, it becomes ovarian. It can still be adrenal in that regards. The most important, the gold standard test of differentiating adrenal versus ovarian etiology is DEXA suppression. So if you give dexamethasone and your androgen levels come down, it means it is adrenal, functional adrenal, or CAH. If you give DEXA and your androgen levels do not come down, it can be an autonomous adrenal producing tumor, or it could be a ovarian etiology. So dexamethasone suppression is an ideal way to distinguish between the two scenarios. And if you go the other way around, if you give GnRH and the level increases, this is ovarian and not a adrenal origin in that regards. So what really is DAST? DAST is basically a dexamethasone androgen suppression test. You give dexamethasone. Typically, we use the same as low-dose DEXA, 0.5 milligram, 6 hourly for 8 doses. There is also a shorter version in which give you 1 dose and then look at in the evening, because in the evening the levels are anyway low. So you may be able to get it, but usually we should follow this long DAST. And in that scenario, if you give dexamethasone, ACTH should come down, cortisol should come down below 40, DHEA should come down below 40 as well, and testosterone should also become low. So a normal response to DAST is a low cortisol, low DHEAs, and low testosterone. But if suppose you have an autonomous problem or an ovarian problem, in that scenario, this testosterone will not come down. Suppose you see that the cortisol is also high and testosterone is also high. What does it mean? And imaging is normal. You have a patient who has got a DEXA suppression in which cortisol is also high and your testo is also high, but there is no anything else more common. So it is unusually to be a topic, but if the patient has not taken the tablet, if the patient is on an enzyme stimulant, which drugs can interfere, cause a false negative? So if you are on phenytoin, phenobarbital, any of those drugs will cause inactivation of dexamethasone. That also, all those things will have a issue in that perspective. So you need to be aware about in that perspective. So if you have an adrenal tumor, these responses will not be there. So if you have suppressed testo, suppressed cortisol, this is CAH or FAH. This is what you can consider. If testo is not suppressed, but cortisol is suppressed, this is ovarian. If both are not suppressed, think of Cushing's, which is primarily there from the, as you said, a macroadenoma and all those things really can do that. Cortisol resistance and poor compliance. Adrenal tumor also will be in the same scenario in that perspective. So ACTH stimulation test can be required, especially when you're thinking of CAH, but this is mainly for non-classical CAH. In classical CAH, your 17 OHP should be very high. So if a 17 OHP is more than 1500, it goes in favor of non-classical 21 hydroxylase deficiency. Then as I discussed, 17 hydroxypregnenolone increase suggests 3 beta HSD and 11 DOC increase suggests 11 hydroxylase deficiency in that scenario. Always measure cortisol levels before you do further evaluation. So suppose your cortisol is less than 138, this could be an exogenous steroid. And we have seen so many cases of exogenous. How are they different from the cases that we are discussing today, Sayan? Your first case was the exogenous one, whom you were thinking of PCOS as a possibility.
There is typical telltale signs of Cushing's syndrome.
So they will have mild hirsutism. They will have more of myopathy, more of Cushingoid habitus, more of hypertension, but they will not have virilization. So this is very easy to exclude. So the cases we are discussing today are all which presented with a significant hyperandrogenism with quote-unquote virilization, clitoromegaly, which was relevant. So that is important to remember. 138 to 276, nothing to be done. More than 376, you have to work up for Cushing syndrome. DHEA, as discussed, can be done any time of the day. It is basically an immunoassay. Levels which are more than 400 are significant. More than 700 are tumor / 3 beta HSD. But as Sayan will show, sometimes you can have a higher level in FAH also. What exactly is FAH, functional adrenal hyperandrogenism?
Adrenal tissues are more hyper responsive to the.
So they are, without any disease, they are producing more. So they are hyper responsive to ACTH. That is what it is, FAH. So if I finally summarize, if you have hyperandrogenism and you know there is significant hyperandrogenism and you find virilization, you look at DHEAs above 700, do a adrenal imaging.
At an 18-year-old female presenting to us with history of gradual change in voice since the last few months, gradual increase in size of a phallus-like structure since the past few years, and menstrual irregularities for the last 4 years. She was apparently well 4 years back when she started to have menstrual irregularities in the form of delay in her cycle dates that gradually progressed to absent menses for prolonged durations. She was on alternative forms of medicine for the last 4 years for these specific complaints. She also noticed a gradual increase in size of the phallus for the last few years. But this structure was also present after birth, but was much smaller in size then.
So there was some clitoromegaly to begin with. Okay.
But the recent complaints which took her to brought her to us was that she was having voice change with deepening of her tone for the last few months.
So could this be PCOS?
Realization.
So there is a definite virilization which is happening. So you have to think beyond PCOS.
Coming to the past history, no history of any known illness, no history of regular drug intake, no history of increased pigmentation. She was born of a non-consanguineous marriage. Perinatal and neonatal period was uneventful. There was no similar family history. On examination, she had a normal blood pressure. She had a normal BMI. She was not obese. There was no stria present, but her FGS was 13. She was all on Tanner staging. Her breast and pubic hair were fully developed, but there was a clitoromegaly of 2.5 centimeter.
So all the three cases we have discussed have a common thing of this second case did not have clitoromegaly.
No.
This girl had a clitoromegaly. So again, clitoromegaly without labial focal feature. So somehow the androgens have woken up now. They are producing more. That is what is happening. So that's why adrenal adenoma again you have to consider. And you are also thinking of simple virilizing form of CAH. Okay, carry on. So what will you do? Investigation wise, what did you do?
So investigations, as the child is virilizing. So the instant report we have is a USG. So we did a USG and had normal ovaries and adrenals in this case. Now the initial reports were as per our presumptive diagnosis. Sodium potassium being normal, cortisol being very low. Now
So presumptive diagnosis of what?
CAH. Simple virilizing CAH.
How low is it? How often they will have cortisol deficiency?
Very rare.
So it is not fitting into your diagnosis. This is very interesting phenomenon. Your cortisol is very low. So in simple virilizing, otherwise she would have had a lot of problems still. So what do you think is explaining that?
These features will be explained by she was an alternative medicine for the last 4 years.
So you have to think of other things. So this is coming on, get the results done.
So this is the back option. This one is back.
No, this is. Yeah, so these were the investigations. So what you are saying is that so your testosterone levels are on the slightly higher side. DHEA's level is not high. 17-OHP is slightly high. And your cortisol is low. So how does it fit into your diagnosis of adrenal CAH cause? It does not fit into CAH.
So by these reports, I can't fit.
So you have to fit into these reports. So what does it suggest? So you have low cortisol with a high, not high testosterone, but she has features of hyperandrogenism.
Yeah. And also the 17-HP is 33 still. So this can't be explained by just these reports. I have to think of something else.
So what do you think of?
So as we had thought at that
level, you look at a cortisol level, and cortisol level is below 138 nanomoles per liter, which will be like 4 or 5 microgram per day. You have to think of
exogenous.
So this is exogenous steroid. So this is very clear there is exogenous steroids. But she doesn't have features of Cushing syndrome to a greater extent.
Because she might be having deficiency. We are replacing that form. So not the overt symptoms.
So she has exogenous steroids, which is not causing Cushing syndrome. This is interesting scenario. And your 17-OHP is still slightly high, but DHEAs and testo is not high. So what it means, whatever medication she is taking in the form of alternative medicines is actually suppressing her condition. That's why she is not having that much virilization as we would have expected in that scenario. So which condition will improve by giving exogenous steroids? Which condition which can cause virilization will improve if you give exogenous steroid in the form of Ayurvedic homeopathic medication? So steroid will improve which kind? What is the treatment? Where do you use steroid?
CAH.
So this could be CAH. So this is what brought us to the diagnosis that 17-OHP is slightly high. And we know, and this again tells you a story. Tells you a story that if you have 17-OHP of 33, still your DHEAS is only 29. So if your DHEAS is more than 1500, you can't have a 17-OHP of 9. Which means that 17-OHP will always be high if it is a primary form. So 17-OHP will be the last to fall if you give steroid. So she is on some alternative medication by which she is getting steroids. That's why her cortisol is low. Testo is relatively normal. DHEAS is normal, but 17-OHP is high. So we then thought of this was more like an art rather than a science that this could be a 21 hydroxylase deficiency. Carry forward.
So this was a final diagnosis, simple virilizing CAH on alternative medicine, causing low androgens with high 17 OHP. She is following with us for the last 6 years and she is doing well.
And what did we find on follow-up was that her 17 OHP actually went up. So her 17 OHP went up when we gave a replacement hydrocortisone. It means that she was getting some very high potent steroids like Visolone or maybe dexamethasone. That's why she was getting control. So this again confirmed the diagnosis, but now gradually she is much better. So again, the big message is don't just rush with the levels and think more in terms of that. So if you have a low cortisol, always think of an exogenous cause in that. So the key message is that if you have hyperandrogenism with pigmentation, with early onset, with variable presentation, with virilization, always think of adrenal cause, get a DHEAS, get a cortisol, and get a 17 OHP. Mostly you will get the diagnosis. If DHEAS is very high, imaging is essential. Always be wary of 3 beta, FAH, 21, and adrenal tumors in that perspective.